ICMA University is pleased to present this online program entitled City Health Dashboard, Using Data to Guide Your Jurisdiction's COVID-19 Response. We are very pleased to welcome all of you to this presentation. I would like to draw everyone's attention to the links box located on the left of your screen. To download a PDF copy of the presentation slides, simply click on the link and a separate web browser window will open so that you can view, save, or print. The webinar evaluation link is also in this area. You must be logged into ICMA University to access the survey from here, but you can also find it on your dashboard after today's program by clicking on the program title. It is my pleasure to introduce today's presenters, Benjamin Spohr and Emily Hunt Hinojosa. Benjamin Spohr manages the data team at the City Health Dashboard and leads the development of COVID Local Risk Index. Dr. Spohr received his MPH from Columbia University and PhD from NYU's College of Global Public Health. He is a spatial epidemiologist who uses geospatial methods and data to explore core public health and social justice issues, health equity, racial, ethnic health disparities, and others through an explicitly spatial lens. When not mulling maps, Dr. Spohr tries to cultivate an emotional relationship with his three extremely reluctant cats. Emily Hunt Hinojosa is the Director of Research and Community Impact for Prosper Waco, a collective impact initiative focused on addressing issues facing the greater Waco community in the areas of education, health, and financial security. Dr. Hunt Hinojosa holds a PhD in sociology from Baylor University, specializing in community analytics, as well as MA in sociology from Baylor University and a MA in higher education and student development from Taylor University. Speakers, welcome to the program.
Good afternoon, everyone. I totally forgot about that deeply dorky line about the cats, and boy, does it sound ridiculous. My name is Ben Spohr, and as you heard, I manage the data team for the City Health Dashboard. And in last month, actually, we developed the COVID Local Risk Index as a sort of response to a deeply felt need amongst our city partners for a way to sort of wrap their arms around how to respond to COVID, how to target resources, how to prepare for the outbreak of the disease that has been progressing across the country. And so I'm here to talk to you today about the index, to help you sort of get a sort of a deep appreciation or understanding of how we came up with it, what goes into it, how to use the COVID Local Risk Index. We're going to talk about some trends across cities and states, and including differences in risk level within cities. And it's sort of great that I can provide a real substantial amount of information for you, and I hope that it's useful. And for me, the most exciting, potentially one of the most exciting parts about this is hearing from Emily from Prosper Waco. You know, Waco and Prosper Waco specifically have really been on the forefront of using the dashboard and using these data. And I'm just excited to hear more from you, Emily, about your perspective on this, because I always learn so much from our conversations. So the first step we're going to take here is, like, what is the dashboard and how does one use it? And so the goal of the City Health Dashboard is to help cities across the U.S. leverage the power of data to improve the health and well-being of everyone in their community. And there's an old adage in the public health world. It's probably not limited to the public health world, but in the public health world, that what gets measured gets done. And what we mean there is if we are not producing data related to an issue, then there's no way for us to get funding, design programs, design interventions around that issue. And I've heard it frequently from our city partners that the standard for the data they include in their funding applications or their accreditation applications, and even in how they approach any problem, has continued to rise to the point that without accurate granular data, it's difficult to push forward the important public health agendas that they all desire to push forward. And one way in which we think about the dashboard is that we're academics in New York City playing with spreadsheets all day. And no one has ever really treated a health problem with a spreadsheet. It's rare that you show up to an emergency room with a broken leg and someone wraps an Excel sheet around it. What we really hope to do is to provide the numbers that back up what community members and community leaders already know. A lot of our city partners already know which neighborhoods deserve additional resources, or where in a city there's insufficient access to healthy foods, or it's harder to walk around. And we can provide the numbers to back up the on-the-ground, expertly situated knowledge. And with those numbers, communities are able to obtain funding, design interventions, and really sort of take off into another level of public health approaches. And so we see ourselves less as an end, and more as a means to an end for city leaders. And the challenge here for a lot of these places is obtaining the data. U.S. cities are responsible for a lot of programs that have substantial impact on public health, either directly or indirectly. Thinking about safe and affordable housing, housing is a public health issue. Where people can and can't smoke, or the price of a pack of cigarettes, is a public health issue. Access to healthy foods and walkability have been gaining a lot of traction, especially in the past few years, as public health issues that used to be primarily business or zoning or public or city planning issues. And as these issues move closer under the umbrella of public health, the way that we think about them and the way we address them continues to evolve. And one of the biggest problems that our partners face is problems of geography, in that up until recently, much of these data were not available parsed to city and neighborhood boundaries. Taking the example of Gary, Indiana, if you are a city leader in Gary, Indiana, it's difficult for you to use data that are parsed to the, for instance, Lake County boundaries. Gary covers a small area of Lake County, and Lake County covers a small area of Indiana as a whole. And while geography and geographic territory is interesting and important, it's also important for us at the dashboard to remember that the populations that live in these places are different. Cities tend to have more diverse populations, and diverse in terms of racial, ethnic composition, in terms of socioeconomic status, in terms of educational attainment, and in terms of health behaviors and health outcomes. And so oftentimes the county data don't provide a totally reasonable proxy for what's going on in cities. Given that, many cities just don't have the data they need to sort of back up their expertise on what's going on in their cities and neighborhoods. And many of these data only exist at the county level. So without more accurate data, many of these cities are making decisions in the dark. And so enters the City Health Dashboard. And to reference the previous slide, sorry, this third slide, we're really trying to find ways to provide the data required to be part of the rising tide that lifts all boats in these cities. And so we have over 35 measures of health, the factors that shape health, and drivers of health equity in 750 cities in the U.S. And one thing that I like about this map is you can really tell the population centers in the U.S. are concentrated in northern Southern California, Texas, Florida, and parts of the Northeast. And it also more importantly demonstrates that we have a number of cities across the country. And, we are conscious that we're using data to make comparisons between places that are very different. And again, that's why we always are keeping in mind that we're a way to empower local leaders. These data are a means to an end. So the underlying sort of theory of change here is that data enables change. And our idea here is that without these data, it is difficult for places to get their hands around or their lines around how their expertise can translate into public health interventions. Our metrics are divided into 5 major categories: clinical care, health behaviors, the physical environment, health outcomes, and social and economic factors. Our clinical care data primarily are drawn from large public health surveillance systems, including the National Vital Statistics System and the 500 Cities data set, which is sort of informed by the Behavioral Risk Factor Surveillance System. And some examples include access to preventative services and prenatal care. Our health behaviors include teen births, smoking, binge drinking, physical inactivity, some others. And again, many of these are from National Vital Statistics System or the 500 Cities data set. Our physical environment data is some of the more frequently discussed among our data sets. We have park access, walkability, and we also have limited access to healthy foods. All of these at the neighborhood level, I believe. Yeah, neighborhood level. And this is sort of a relatively new way to think about drivers of public health, in that we have been talking about social determinants of health for a while now, though it's still relatively new. And these physical drivers, physical environment drivers, have emerged in the scene, especially limited access to healthy foods, as a new way to look at how cities can help improve population health. Our health outcomes include overwhelming majority of these outcomes come from the National Vital Statistics System in 500 cities. Some of the highlights here: opioid overdose deaths, frequent mental and physical distress, the life expectancy measure from USA LEAP, which is sort of an excellent totalizing measure of public health outcomes, and then, of course, our recently added COVID local risk index. And then our social and economic factors are primarily drawn from the U.S. Census and include some of the sort of foundational social determinants of health: poverty, high school graduation, income inequality, employment. One I'd like to highlight here is excessive housing cost. This one is relative to not only what the income is like in a given place, but also what the rent costs are in a given place, because it's a percentage of individuals paying more than 30% of their income towards rent in a given location. And while there are different definitions of excessive, we use that one, and it sort of it's a interesting economic measure. And this is our the full list of our metrics, and you can see that the ones typed out in blue are available at the city level only, and the ones in gold are available at the neighborhood or census tract level. And some of these, for instance, breast cancer deaths and cardiovascular disease death rate are available at the city level because we want to preserve individual privacy by not disaggregating data to a point where there are few events. And for these specific causes of death, there are few events at the neighborhood level. Some other of these are at the city level because the data are not released at a lower geography level, thinking about specifically violent crime or primary care physician count. And we are sort of always striving to provide our users with more granular data that are available at the neighborhood level. And that's one of the features of the COVID Local Risk Index that we think is most important, is that we can look at within city neighborhood level variation. So at this point, I'm going to provide you a real-time demo of the dashboard to sort of walk you through what someone might see when they're looking at the dashboard. And if in the next few moments, any of you can type in a large U.S. city into the chat box, I'll be able to use that city as our case example. And I'm going to give us maybe 1 minute to type one in here. I've got Tampa and Tempe, so we're hitting the T's. Thank you, CM Park in Waddale Homes. I think that's Waddale. Thank you so much. And I've got a lot of other examples here. We'll try to flip around to different geographies a little bit if possible. Okay, I am going to skirt my screen. So what you should see in front of you is the landing page for the City Health Dashboard. And the first thing I want to draw your attention to is that you can navigate to a lot of different parts of the website through this, what our developer keeps calling a hamburger menu, which is not at all a hunger cue for us when we're in web development meetings. And I want to underscore right now that the overwhelming majority of our data are publicly accessible through our data access page. You can click here. We do ask just a few questions so that we can reach out to folks when our data change or are updated. And then you can get a state level or national level file with all of the data we're capable of releasing. Our COVID Local Risk Index is not currently included in our downloadable data, but we are happy to field requests for that via email. And you can reach out to me or find the contact info on our website to get that. So now that I've talked for a few moments, the city name I remember is Tampa, and so we're going to Tampa, Florida. And what I want to highlight here is that all of our 756 cities are available via this drop-down menu from New York City, which is, I believe, our biggest city, to some of a handful of smaller New Jersey cities that we added through a collaboration with the New Jersey Health Initiative, for instance, Egg Harbor City. The population range for cities on the dashboard is currently 2,000 to 8 million, and some of those smaller New Jersey cities round out that bottom group. So let's go to Tampa, Florida. The next choice you're presented is to select a metric. And we're going to take a deep dive into COVID Local Risk Index a little bit later in this conversation. So I'm going to start with life expectancy, which is one of our other most frequently selected and popular metrics. So if you click through the life expectancy, the first thing you see here is the scale bar. And what the scale bar shows you is life expectancy in Tampa at the city level with this gold bar. as compared to the national average. And we can already see that Tampa is lagging just a little bit in life expectancy, about 1.6 years lower than the dashboard average. As we scroll down, we see a map, a census tract level map of life expectancy in Tampa, and we can zoom in with the plus and minus keys here. And as you can tell from this scale bar, darker colors darker colors mean less desirable values. And as we hover over some of these darker colored census tracts, we'll find that life expectancy is lower in some of these places on the lower end of the spectrum at 64 years here, 68 years here. But right next door to this tract in which the life expectancy is 68, life expectancy here is 76 years, is 8 years longer. And this is one of the big strengths of the dashboard, is that we can sort of visualize differences in health outcomes very quickly and get a sort of a visceral level knowledge or understanding of how some health determinants might translate into health outcomes. So I think what I'm seeing here is that Tampa's highest life expectancy is 87.3, and this scale bar suggests that's close. I don't know that we'll spend a lot of time looking for a higher one, but you know, we're not but a few miles apart here, I believe. I don't know Tampa very well, and I apologize to the person who suggested this. I've not spent any time in Tampa yet, but we've got 64 years here and 87 years here, and that right there is sort of an attention-grabbing headline for any grant application. So I'm going to change metrics. We change metrics to, for instance, I'm going to choose one of our census-derived metrics, because then we can get a demographic detail on it. We'll see that this area in which there is high life expectancy, there's also relatively low children in poverty. And we've got some higher values in a couple of these places where there was lower life expectancy. If we click through, and you'll notice that these arrows sort of suggest a user journey. If we click through to demographic detail, we'll find that there are substantial differences, I'd even say disparities, in the percentage of children living in poverty across racial ethnic strata. And the percentage of Asian and white children living in poverty is lower than average, and the percentage of Black and Hispanic is higher. And in a couple places across the dashboard, you'll find these sense-making statements. The percent of children in poverty among Tampa's Asian population is lower than the average percent of children in poverty for the Asian population across the dashboard cities. So we know that these are big, complicated sentences, and we hope to write them out clearly enough that even folks who don't spend all their time thinking through data systems can find these data useful. Now, we're going to click through to the Compare Cities tool. And what this allows us to do is find cities that are, broadly speaking, similar to, sorry, I'm jumping around a lot, so it's the nervous scrolling, that are similar to Tampa in a number of important ways. And I think that from my standpoint, the most useful part of this tool is the filter to find or compare cities, because someone in Tampa might say, you know, people always compare us to St. Petersburg or Miami, and you know what, we're not sure that that comparison really makes sense. If you click through to find comparison cities, you can find a couple of major categories, demographic categories, to compare your city to other cities, to find cities that are similar in important ways, similar in terms of population, location, or racial ethnic breakdown. You can also find cities that are similar to your city in terms of numerous, pretty much all of the dashboard metrics here. So we're going to be adding soon to this section of the dashboard the ability to filter by city types. And we've created a pretty interesting way to look at city typologies and how those city typologies affect health outcomes. And this is sort of a coming soon. If you are getting excited about the data we provide here, we're going to release that report and those metrics in the near future. So we're going to move through here to compare metrics. And let's say that we want, I'm going to change city because I think we spent enough time in Tampa. I saw Tempe. I'm going to go to San Jose because I'm from Northern California. And I'm the presenter. I can play favorites. So we're in San Jose. We can see that poverty in San Jose, children poverty in San Jose is a little bit, is about half that of the national average, of the dashboard city average, sorry, the average of cities on the dashboard. And it's important that I highlight for many of our metrics, you can go back in time and see that percent children poverty in San Jose has changed over time. It's actually lower in 2018 than it was in 2013. Now let's say that we wanted to compare a metric here, and we know that generally speaking, children poverty is related to obesity, so we're going to add obesity here. And I'm just going to update this metric year to 2017, so we have the same metric year. And these two scale bars here sort of give you the information you need to interpret the ensuing map, which is that darker colors mean higher poverty for children in poverty, and darker circles, darker dots, mean higher obesity. And so what we're going to expect to see generally is that darker polygons will correspond with darker dots. And if we zoom in a little bit, sorry for anyone who gets a little motion sickness on this one, it's an abrupt zoom, we can see that relationship sort of playing out a little bit. We'll just click on this one. So we'll hover over this one. We have 0.8% children poverty, which is very low, and comparatively speaking, low obesity at 12.9% here in this northwest corner of San Jose. And then in this more central portion, we have a 35% children poverty and almost 29.2% obese. So in some of these places will not, some of these census tracts will not have as clear a relationship, but if we scroll down a little bit, we'll get a scatter plot. And for those of you who remember drawing regression lines or correlation lines through data, you can sort of generally see a positive correlation here. And that's what we would expect based on what we know about the relationship between poverty and obesity. So the final feature I want to show you here is the Take Action section. The Take Action section is, we're going to change metrics to obesity here. The Take Action section helps users find resources and on how to address a given health issue. And so I think I'm having a little bit of trouble loading the obesity resources, but we'll change back to life expectancy, which I know should produce. And then if we click here to policies and programs, you'll find, for instance, a list of policies and programs that have been proven effective for addressing life expectancy at the city and neighborhood level. You can also find partnerships, explore strategies, find funding, which may be one of the more important features here, and measure impact. So I'm going to stop the tour here and just bring us back to our slides. I'm so glad that I chose Tampa because I've seen like 4 folks that asked for it. So I've lucked into the to the right city here. I'm going to take just a moment here before we dive into the next section, and if it doesn't and answer two of the questions that I have here, because I think it's really important for us to get a strong foundation for these data and to demonstrate, or at least answer questions about where they come from before I ask you to believe what we have to say about COVID. So if you have any questions, please type them in. We're going to take a few here. So a question from Freddie Coupin or Cuppin Ames. I'm sorry if I'm getting that wrong, Freddie. How can cities assure the public of new data and measurements regarding COVID when there have been some changes to when the data goes and how it is being disseminated, i.e. hospital data used to go to CDC? Freddie, this is such a smart question, and we have spent a lot of time recently, we'll continue spending a lot of time thinking about how COVID affects data systems. COVID data, specifically case rates, positive tests, has become a political entity, and it's difficult to get comprehensive data about where COVID is happening and in what quantity. And so we are validating. I'll show you. We're going to talk a bit about validation of the COVID index in a little bit, and so I'll save some of that for the next series of slides. But only to say that the end of that slide, end of that argument is we believe that more of these data should be made publicly available at a granular level, at the census tract level, so that it is so that we can further pursue validating the work that I'm about to describe to you. And then David Schulke, I hope I'm getting that right, David. When you say neighborhood level, quote unquote, are you using 9-digit zip codes like the Area Deprivation Index codes, or some other way of identifying neighborhoods? David, great question. Our team has reported dreaming of different neighborhood geographies instead of sugar plums during the holiday season. We use census tracts. And for those of you who don't have dreams about census tracts, census tract is a geographic unit. Boundaries are drawn by the census. It has between 1,500 and 8,000 residents, usually around 4,000, and it's used for statistical comparisons across census years. And it also happens to be roughly the size of many neighborhoods, or at least as close as many researchers can get in administrative data. And so while census tracts, for many reasons, don't always perfectly align with how people understand their neighborhoods, especially in places with high population density, it's sort of the most frequently used and closest analog to neighborhood level data we can get, and sometimes the census tracts give us even more geographically granular data. And I think I'm going to move on here and I see a question about how data collected and are we able to download data from the dashboard. I'm actually just going to screen share for one more moment about the data question, and then we're going to move forward. Freddie, you said, can we get these data? And we would love nothing more than for you to grab our data and use it. If you go from any part of the dashboard to this hamburger menu, click on Data Access. We're going to ask you for a little bit of information, and we use this to reach out when the data are updated so that you might use the most accurate and updated information. But if you fill out the survey, you'll be able to access downloadable CSVs that have all of our metrics with some key exceptions at the city and census tract level, and you can get them for the whole country or you can get them just for a specific state. And we don't provide the COVID data on these downloadable data, but you can get them by emailing us directly. And then, Seung, part, how are the data collected, what are the sources? We have a number of different sources, ranging from one-on-one data agreements with private companies to using publicly available data from the census or from the 500 Cities Project. There's a lot more information about that on our tech doc, which you can download at the bottom of our homepage or the bottom of any page on the dashboard. And I'm happy to answer more specific questions because, you know, I think that if I tried to tell you the data source reach 35 measures, I get kicked off my own webinar because it would be too much information. Okay, back to our slides. So the COVID Local Risk Index, what is it, how did we create it, and how can you use it? State and city, so we heard from our partners that folks really needed a granular data, like neighborhood level data to guide COVID preparation and response. And in looking through the existing data tools at the time, we found a space that a way that the dashboard could create an index that would be really helpful. While other data tools existed, many of them did not use exclusively neighborhood level data, which we think is essential to understanding what's going on within a city and within a neighborhood. There was some focus on access to healthcare services, which is an important contributor to what's going on in the COVID pandemic, and we thought was a different angle than we wanted to take on it. And many of them did not incorporate clinical factors related to the severity of COVID outcomes. And so the purpose of our COVID Local Risk Index is to provide city and state stakeholders granular information about city and neighborhood level risk. And the idea here is that we want to help cities and states allocate resources to the communities and to the cities within states at the greatest risk for COVID infections, a high risk convection of spread, and for severe COVID outcomes. And I want to be really clear here that we don't think this is useful for predicting case counts or mortality. There are a lot of stuff going on out in the world right now that is related to case count and mortality that we cannot measure or do not measure in the index. Thinking about risk of infection specifically, variation in access to testing, variation in travel patterns and local super spreader events are not included in the index and can have a big impact on case rates. And health systems and health care access can affect mortality substantially, and granular neighborhood level data are not available for these factors. So we could not include them in the index. So here's where we're going to get really technical, and if you're not, if you don't really enjoy nitty-gritty data stuff, this is a great point to maybe think about your trip to the grocery store, or imagine what it was like if I wasn't about to show you a massive, overwhelming table, because I'm going to do that. I'm sorry. The index is comprised of three primary groups of variables. The first is the CDC's Social Vulnerability Index, and I really want to highlight the SVI, the Social Vulnerability Index, because it is publicly available for download, and it includes every census tract in the U.S. And we are not able to cover every census tract in the U.S. with our data, and the SVI does. And it captures some important information about potential risk of COVID transmission, and it has a little bit better coverage. And the SVI is a combination of demographic and economic variables that are drawn from the U.S. Census, and it was intended to and originally capture tract level susceptibility to natural disasters. And there is a non-trivial way of thinking about COVID as a natural disaster. Not quite perfect, but it's in the ballpark, perhaps. And the SVI has been independently validated, statistically significantly correlated against case rate data, and is used in some other data tools. And so there's sort of building a body of evidence that SVI is a useful way to think about risk of COVID transmission. On top of the SVI, we added clinical health conditions that are related to severe COVID outcomes. And I want to acknowledge right here that our understanding of COVID and COVID outcomes is evolving rapidly. The literature base changes frequently, and in the early days of this, especially I would say 6 weeks before we created the COVID index, there was some debate about which clinical factors might primarily drive severe COVID outcomes. And while we're always refining, we're still learning, and that debate is not by any means over. What we have found since we've released the COVID index is a lot of the emerging literature sort of builds upon the factors that we include here and provides further evidence of their importance. And I'm going to have a list of the specific health conditions in the next slide. And then group 3, we have 2 demographic factors that merit additional weight or emphasis. And that's the age distribution and percent mortality. And we weighted these variables according to evidence based on sort of our understanding of the literature available at the time. And I'll talk a little bit more about our upcoming review of the index later on. And now I'm just going to take a deep breath because I'm about to show you a huge data table. Here we go. Here's the huge data table. What we have here are the 3 themes I've just described to you under the theme column. Our data source, for those of you who want to go take a look at it yourself. How we decided the weighting we assigned to each of the categories, and then specific components of each of these 3 themes. So we, for instance, weighted the social vulnerability index at 45%. And we also weighted the health COVID-related conditions at 45% because we didn't have a substantial body of evidence that suggested which of these to weight more heavily when thinking about the total impact of COVID at the neighborhood or city level. And in the face of that equipoise, we wanted to equally emphasize the risk of transmission, which we believe is risk of infection, which we believe is captured by the social vulnerability index, and the risk of severe outcomes, which we believe is captured by the chronic health outcomes. We distributed this 45% weight over the variables included in the social vulnerability index, which breaks down to about 3% per component. And a couple of variables I want to highlight in the SVI, in the social vulnerability index. We have persons age 65 plus, and we have percent minority, which are similar to the demographic factors that we believe deserve extra emphasis. And what I think is perhaps most important in the SVI, among many important variables, is the variable in bold towards the bottom of the SVI list in group 4. At the household level, what percentage of households have more people, more residents than rooms? And this is an overcrowding measure. And we know there's mounting evidence that that transmission indoors is important, and the more people that are living in a given place, the more likelihood of transmission if one of those people is infected. And so that one stood out as an important component of SVI. Below that, you'll see the list of chronic conditions that we included, and you'll see that we did not uniformly distribute the weight, the 45% weight amongst these chronic conditions. We weighted some more highly based on the existing evidence and what the existing evidence suggests would be more impactful for severe COVID outcomes. And then finally, we have added some emphasis to percent minority, and then added more emphasis to older age groups, because there's, again, mounting evidence that older individuals have more severe outcomes, and that the severity of the outcomes increase as individuals age. And I'm just going to divert for a moment. Ronald, for group 3, it says age and percent minority, but I said age and mortality rate, which is correct. Thank you, Ronald. Mortality rates are not included in the current version of the index. We could not get those data, and those are sort of the outcome of higher risk, so I don't know that we would include it if we had them, so I should not have said mortality. I should have said age and percent minority. Okay, so let's get off of this table. So what do we believe the index should be used for? We think it should be used to guide resource allocation. It could be used to direct testing and outreach efforts. Identify neighborhoods that have more or fewer than expected cases. That one's taken directly from Emily. High five, Emily. Thank you so much. And we also see a strong potential for cities and states and neighborhood organizations to advocate for more resources if they are in a high-risk group, or if they, if they have a high-risk score, or just for any reason at all. I think that we all have good reasons to want to advocate for more COVID-related resources. It's also important to highlight what we should not be using this for, and I spoke about this a little bit earlier, but to reiterate, this is not meant to be a predictive tool because there's a lot going on that we can't capture using the index. And so we don't expect cases and mortality or hospitalizations to track perfectly, but we do expect them to be correlated. And so it should not be used to predict in a specific sense either case counts or deaths. And given that we don't think it should be used to predict case counts or deaths, we also don't think that you can necessarily evaluate specific prevention efforts using the COVID local risk index. I don't think it makes sense to say this place has a high COVID local risk index score, but low cases, and so it must mean that whatever we did here helped. We being, for instance, some public health intervention. I do think that it makes sense to make the sort of comparisons that Prosper Waco has made, and Emily's going to describe those in just a moment, but I don't think this is a good evaluation tool. So, so does it work? So the ultimate question with a tool like this is, are the data valid, and is the COVID local risk index track sort of with what we know about transmission or severity of outcomes? And this is a little bit difficult to answer. And the reason, one of the many reasons it's difficult to answer is that, as I said previously, the COVID data have become a political entity. We have only been able to find granular COVID-related data for 2 states, for Louisiana and Wisconsin. And that's a limited, those are not, for instance, Texas and California, where we have an overwhelmingly large number of cities, or Florida. And so we're only able to validate the COVID index against a few cities, and I will say that what we have seen so far is encouraging. The index is statistically significantly correlated with positive case counts, confirmed cases at the census tract level in these places. Correlation is moderately strong, and we're performing similarly to other publicly available COVID data tools. What we think is more encouraging is that our conversations with cities, in our conversation with cities, cities have said, this tracks. These data, this map, or whatever we're looking at, sort of fits with what we expect to see based on our internal data and our internal testing. And so how would you think about this? We think about this as, it's early days. There's a lot to learn. Many of the data we need are inaccessible, and the early indications are positive, are that we're capturing important information about COVID, risk of COVID transmission, severity of COVID outcomes. We've also seen substantial uptake in local press. If you are a Charleston resident, you can find by Googling WCSC Live 5 Charleston City Health Dashboard, a really interesting and well thought out local news clip about what's about how the local Department of Health has been using and some community organizations have been using the COVID Local Risk Index. We also have a number of news clips. One of them is in Manchester City. Manchester City officials took a look at the COVID Local Risk Index on the dashboard, identified neighborhoods in which there was high risk scores, and encouraged folks in those neighborhoods to go get tested for COVID. And this is sort of our ideal use case. It's saying that, hey, there are some reasons to believe that risk is higher here, so we should concentrate resources here. We also, after the story went out, our site traffic doubled, which means and we believe a lot of it was from Manchester and people taking a look to see if they were in these neighborhoods so they could go get tested if necessary. We also seem to have been written up by most of the cities in Arkansas that are also on the dashboard. We got news clips from Jonesboro, from Fort Smith, and another one written in Jonesboro, but I think talking about a different, no, also about Jonesboro. So we have engaged in some conversations with folks in Arkansas, and when we asked them, you know, does this track for you, what they said is that in Little Rock, the interstate I-630 was sort of planted in the middle of Little Rock, and it was constructed in such a way that it ran through minority neighborhoods, primarily black neighborhoods, and the interstate became sort of a dividing line, a red line, if you will, and that as expected, they're seeing different case counts on different sides of I-630, and so while this tracks, or this is what we expect, is not sort of the big data validation that my deepest heart needs, it is telling us that local city users are finding our tool useful, and it's giving them information they need and they find actionable. And with that, I'm going to give you another voice to listen to for a moment. Emily, I hope that I haven't lulled you to sleep with my narration. I think this is the moment in which I want to pass it over to you for you to give us an idea of how you at Prosper Waco have been able to use the index.
Great, thank you, Ben. Happy to be here and share what we've done in Waco. So Prosper Waco is a collective impact initiative. We are not kind of formally part of the city management, though relate very closely to health leaders, city leaders, superintendents, leaders across our community. And so, you know, everyone, including everyone on this call, I'm sure has felt the need for quick, meaningful data to figure out what to do. I mean, that's really the quest behind all data, is trying to do more than a shot in the dark. And I think that the COVID Local Risk Index is much more than a shot in the dark, though I would say, as Ben mentioned, it's an experimental data product, just as, you know, there are a number of these data products popping up everywhere trying to give all of us a sense of what's going on and what to do. And so we have been a part, in Waco, we've been a part of using the City Health Dashboard before this index. So we were one of the pilot cities and have been familiar with the data in the dashboard. And so, Ben, your presentation before was just kind of reminded me of all the great features and just the accessibility. And so I think there's two things worth mentioning. One is that the importance of that, of looking at the granular geography, is really, the question behind that is, not just what's happening in my community, but for whom are things better or worse, and where. And so I think, especially with COVID, that has really become more of a pressing issue as we're all trying to think about where to target resources. And so what we did in Waco, just a quick background, and I hopefully we'll have time to answer some questions, because this is an ongoing thing. We have used this risk index to really, I would say, use it as a window into our community, not as a predictive endeavor, but really as a starting point for conversations, and a starting point for formal and informal hypotheses. So our city, according to this kind of ranking mechanism, scored a 9 in our city, which is high for risk, according to this index. And then we identified 16 communities, neighborhood census tracts within Waco, the city of Waco, that either scored a 9 or a 10. 5 that scored a 10 and 11 that scored a 9. And so, again, this index, I don't know that it can tell us everything, but it can tell us something. And so as we're thinking about where risk is concentrated, that was a starting point for us. I mean, I think we, intuitively thought about different demographic issues or access to medical care, things like that the dashboard provides us prior to this index, but having it in one spot was really helpful. So we identified those neighborhoods, and then started just to kind of use it as a trailhead. So of the 5 neighborhoods at the highest risk that scored a 10, what do we know about those places? So our testing data at the moment is we do not have it at the census tract level. We have it at the zip code level, but are working to get that data from our public health partners to see if, if you score a high risk, if you have a high risk score, but then you have a low case count, does that imply testing, or the question that I had was, are there other factors going on in this particular community that could be, mitigating risk? I think there's 2 ways of viewing the situation, and so we've used this tool to reach out to community organizers in Waco and kind of ask those questions. And one of our community organizer friends, I posed this about one of our neighborhoods. I say, look, we've got a 10 in this one census tract, but the case count seems to be quite low. What do you think is going on? And so, if we can rule out the testing issue, that there's adequate testing, or at least comparatively adequate testing, then it becomes a question of what are the protective factors. So, they pointed out to me, well, the first death in our community was a principal in that particular neighborhood. So despite being high risk, there are many reasons that residents are taking COVID quite seriously in that particular community. So I think that's one way that we've used this. I think another is we've kind of, obviously data does not always come, coming by census tract, it does not come in the jurisdictions that maybe are most helpful. And so we've done a mapping project, mapping out risk across city council districts to identify which districts are kind of which parts of a district are most at risk. And then we've also looked at some other data. You can go to the next slide, Ben, I think. We've looked at other measures at the census tract level to see what might be driving that risk. So Ben mentioned a few other indicators. We've used the Sergo Foundation's index to see, is it demographic issues, is it health issues, what might be driving the vulnerability. And I think the reason that I love, I appreciate all these questions about method and validity, because I asked Ben, before I downloaded this data and kind of dug in, I said, okay, how do we validate this? How do we know this is the right thing to measure COVID risk? And what I do appreciate about this index is that it is using data at the census tract level, not at the county level or the state level. And I think for our community, you know, we are not a big city by any stretch of the imagination. This granularity becomes even more important as we're thinking about targeting our efforts. So we, I would say, at the very worst case scenario, this has been a way of starting conversations in our community about who's at risk, and then thinking about why that might be the case. And some of that has been quantitatively oriented, right? We're looking at, what number of essential workers are concentrated in this particular high-risk area. What is the access to testing in this particular neighborhood? What clinics are available? What other factors could be driving this? So that is kind of a nutshell of how we've used this in Waco. I'm happy to answer any questions. Again, this is ongoing. We are in the midst of rising cases and rising challenges in our community. And so we're still kind of drawing on this index to help us think through what to do.
Emily, I really appreciate it, and I thank you for also naming the Sergo Index. We thought a lot about the Sergo Index and learned from them. Also, I realized I did a very bad data person thing and didn't tell folks the following. The COVID Local Risk Index ranges from 1 to 10.
Oh, yeah. I
never said that.
We did not have a good score. I mean, that was one of the things is that, our whole city scored a 9, which was a challenge. But then to know that there are certain places that are kind of driving that number up. And again, I would say, like Ben said, it really tracks with what we know of our community. And one of the benefits too, I mean, I think that the City Health Dashboard in and of itself is a great community-facing tool for, city leaders to draw upon. I also think for the number crunchers among us, having the data, being able to download it and kind of do your own mapping, your own analysis is a great resource across these indicators, but particularly for this COVID index. So we've kind of taken it and run with it. We've moved we're not using the dashboard as much as we are the data. And so I think both of those are on offer here, right? One is the community-facing tool and platform, but the other is the data and thinking behind it. And so we're a data-driven organization, and so have our own community data tools, but having the index to work with in our own way has been a great resource.
I so appreciate that perspective, Emily. I'll say, I know someone asked about downloadable data. We do provide the data for download. I'll have my contact info at the end if you want the COVID data specifically. And to the point about it being documented and thought through, we have an extensive technical document. It's like 80 pages. And we actually, when we were working in the office, we had a jar, and we put $1 in the jar every time somebody said they actually read something from the tech doc, because that's where all the good information is hidden. And it is also very technical, and we love to find number crunchers alike in spirit. So, Emily, I'm just so grateful. And I will say one more thing here is that our collaboration with you, Emily, has sort of been one of the ongoing partnerships that has inspired us through this insanely challenging, very overwhelming time, because we are seeing the work that we do and the thought that we put into it translated directly into the type of action we're hoping to see it translated into. And it's sort of, it's a little bit of a candle. It's like a light at the end of the tunnel for us in some ways. And so, I say that not just to tell Emily that she and Prosper Waco is fantastic, because that's true, but also to highlight that, like, we really want to work with you, whoever you are, whatever you're doing, on these data. And it's not only that it's important for our feasibility as a program, but also it's what inspires us. And so my email address, I'm gonna have it out here at the end of the slide. And if any of you want to collaborate or have questions about these data or have any issues with the data access, don't hesitate to reach out to me. And Emily, I'm so grateful for your time. Folks, Emily, I believe you have to hop off just right before our time. Is that correct?
Yes, I do.
Yeah,
but
so
one more thing.
Go ahead.
I just want to say one more. Oh, let me say one more thing, and then you can finish out. I will say this. Another, I would say, good thing about having an index like this, even though indices kind of are challenging in and of themselves to really understand a problem, I think in this moment where we need quick understanding, it is a great thing. And then secondly, it creates a conversation, a language that health partners, city leaders, schools, a variety of different kinds of institutions that are all trying to do the same thing, can look at the map and figure out, okay, where do we concentrate our particular efforts, whether that be health efforts or targeting testing issues. I think it creates a common language that if you just focus on health data or demographic data, you really kind of miss a picture. And so I think it is a common language tool. Go ahead, Ben.
Thanks so much, Emily. Another excellent point. I'm just going to divert for a second and say, David, thank you so much for the Williamson Nature recommendation in the comments. I think I'm going to describe the process by which we're going to update the index in a moment, but this article is definitely on the top of our list, and I definitely think it'll be helpful. So I'm going to recap some of our findings, and then I'm going to leave some time for questions here. So here are some of the cities in the news and their city and neighborhood range, right? Miami, city score is 10, the highest possible risk score, and the neighborhood range is 1 to 10. Jacksonville, the local risk index score is 10, and neighborhood range is 1 to 10. Dallas score is 6, neighborhood range is 1 to 10. Dallas scores 8, range is 1 to 10, and Phoenix scores 6, and neighborhood range 1 to 10. And the city level score is important and provides important information. And I want to highlight the range here. I might have this on the next slide, but 40% of our cities, 193, this is the bottom bullet here, have a neighborhood range of 1 to 10. And I'm highlighting this because some cities have low overall risk scores and then have a census tract or a cluster of census tracts in which risk is higher. And we want to be really careful to, and this is the point about ethics, to not be saying these are the bad neighborhoods or something's wrong with these neighborhoods or these neighborhoods should be singled out because they're high risk in a bad way. What we want to say is that cities that have any sort of risk score but may have a cluster of higher risk neighborhoods should be providing resources and thinking about who lives in those neighborhoods and what those people need in order to prevent or reduce COVID transmission and severe outcomes. Because the risk, I think, here is seeing a low city level risk score and thinking, oh, our risk is low, we are safe, and then doing a thing that folks have been doing for decades, which is not really thinking about health equity and not being careful about supporting everyone who needs support, especially in the face of this new public health challenge. And so this is why I think it's so important to take a look not only at the city score but also the neighborhood range and identify those places in which neighborhoods may be at higher risk. There are also substantial variation across groups of states. Excuse me. What you see here is a box plot of the average COVID index value score by cities at the city level within census divisions. And the diamonds are the averages. The lines that you see within each box are the median values, and the 25 to 75% values are covered by the rectangles. And what I want to highlight is that the Mid-Atlantic division, which is New Jersey, New York, and Pennsylvania, the average here is I believe 8.2. And then down at the mountain region where we have Arizona, Colorado, Idaho, New Mexico, a handful of other states, the average here is somewhere around the 3.5 range. And so we are seeing substantial variation by census division and to a lesser extent census region. And so there are some geographic patterns to the COVID Local Risk Index, which I think are important to think about, and we're sort of still thinking through how to use these or what these differences mean. So that brings us to the present moment. What do we do now? The overwhelming majority of our data are available for download at cityhealthdashboard.com. If you are interested in the COVID data, which we do not provide in the publicly available data set right now, you can email me and I will send you, or someone from our team will send you this data files. And the reason we don't provide those publicly is that we are cognizant that the understanding around COVID is changing rapidly. And we sort of wanted to balance the importance of providing these data with urgency. We want to balance that urgency with making sure that these data are as accurate as possible, that the COVID Local Risk Index accurately captures what's going on with respect to COVID risk. So, at the end of August or beginning of September, we're going to do a reevaluation of the COVID Local Risk Index, and we're going to be looking at the recently published literature, including the Williamson Nature article. We're going to be looking at variables that we thought about including, but we could not include in the first go-around, potentially transportation, public transit access, and the degree to which individuals are sheltering in place using mobile phone data. And we may change the weighting or the variables or other things about the index. And if we do, we want to be able to contact everyone who has the data and say, here are the changes we made, here's why we made them, and here are the new data. So this is partially a reminder that this is work in progress as we continue to learn more about COVID, and partially please use our data and know that we're going to update it, and when we do, we're going to reach out to you. And that gets on to my other point here, which is we have a huge appetite to work with anyone who wants to work with these data or use the dashboard. So please don't hesitate to reach out. And then in closing, before I leave about 15 minutes for questions, I want to say we've all gotten used to some very unusual, I think unusual is not strong enough, some pretty upsetting circumstances. And for those of you who have made it to the end of this webinar with me, like, we're all struggling in our own ways. My cats are not nearly as demanding as, for instance, children might be, and I still find a way to struggle through it. So I hope that you all are well or are getting well, and I certainly appreciate you spending this time learning about the dashboard. And now I'm going to open this up to questions. So please don't hesitate to drop them in the chat box if you've got them.
Thank you so much, Ben and Emily. At this time, we will open it up for audience questions. We thank you for the questions that you've submitted so far, but just as a reminder, to submit your question through the web conference system, simply type into the chat box located at the lower left of your screen, and then be sure to hit that send button so that we're sure to receive the question. So just give it a moment or two to see if anything comes in. And while we're waiting, Ben, if you want to start out with a question that maybe you're often asked that you think would be worth mentioning or expanding on, feel free to go ahead.
Yeah, I think that I can get a little bit further into the data sets here, which I wasn't able to answer fully previously. The primary data source for the metrics on the website is American Community Survey, U.S. Census data, followed closely by the CDC's 500 cities data set, which provides small area estimation, census tract level data based on the behavioral risk factor surveillance system. A number of our metrics are derived from a data use agreement with the National Vital Statistics System. So we, in more typical times, have gone to the restricted data center in Maryland, sat in a special room, and worked with mortality files to produce some of the health outcome data you see on the dashboard. And after that, many of our data sets come from, I'm sure this is getting a big one, but many of our metrics come from data use agreements with private contractors. For instance, our park access data comes from ParkServe, our walk score data comes from WalkScore. Our violent crime data comes from analyzing the Uniform Crime Reporting database. And, you know, these data systems are going to be differentially affected by COVID, and so we're sort of keeping an eye on how these public health surveillance systems are impacted. And it's really an open question.
Well, thank you. We do have a comment from Julie, and she just says that she appreciates the information and learning about this resource, and thanks you for sharing. We've also had a question come in from Ronald. Is there any chance the COVID geospatial data might be given at the census block level at a later date?
Thank you so much, Julie. I'm sitting here talking to my computer, which doesn't have a lot of feelings. So it's nice to hear this connected for someone. Ronald, I appreciate the second question here. The COVID geospatial data, a couple ways to answer that. Many of the components of the social vulnerability index are available down to the census block level. I believe I'd have to double check before I can give you a 100% confident answer, but I'm pretty sure that's the case. However, the clinical factors that we include are available at the census tract level only. And so we can't drill down to the block level. And for those of you who don't know what this means, the census blocks are nested within census tracts. I believe it's about 4 blocks in each tract, but I'm not totally sure that's right. I'm going to have to double check that. But anyways, they are a geographic subcomponent of the tract. And so that gives you an even more granular look, geographically look at these data. So the short answer to that is not for the clinical outcomes, but yes, for some of the demographic factors. We won't be processing and releasing those, but they are available via the data.census.gov, the new U.S. Census Data Access website. I also want to mention we, in addition to the data downloadable files, we have an API. If you are a savvy computer person, you can grab the data through our API, which you can find out more about on the website, cityhealthdashboard.com.
Wonderful. Thank you. Next question. How often will the database be updated and distributed to us when we sign up to receive it?
Yeah, but Bettina, I think that's Bettina. I'm sorry if I'm getting this wrong. Bettina Lee. You know, we know that we're going to update it in late August, early September, and I think that we're probably going to do a quarterly update after that or something in that range, and it really depends on how quickly our understanding of the COVID transmission evolves. I also think that we may update it less frequently if the evolution of the data slows down, or if a vaccine becomes widely available and there's no longer questions around our ability to prepare for and respond to the outbreak. We will let everyone know when we change the data, and that's the primary reason why we ask people to email us to get the COVID data specifically, is so that when we make these updates, we can let you know that there's fresh new data off the data assembly lines.
And it looks like we've got one more question in the queue so far. What are your thoughts or plans on including additional financial metrics on the City Health Dashboard?
Ladale, this is a great question, and boy, let's do a whole another hour and a half. We have started a partnership with the New York State Federal Reserve Bank to think through these financial metrics. And they have recently released something called the Credit Insecurity Index, which measures a city's the ability of the residents of a city to access credit at choice. And so they sort of see this as an intermediate point between what goes on in people's financial situations in a normal time and financial distress. If something happens to a person that stresses their financial situation, credit is one way they might be able to cope with it. And there's a lot to think about with this metric, and we're sort of working on whether we think it's a good financial measure, both in terms of measuring preparedness and potential response to the outbreak. In addition, we're looking at posting personal bankruptcy rate. We believe that personal bankruptcies will increase over the course of COVID and for years to come, potentially years to come after COVID, if there's a recession, which is looking increasingly likely. And this is a sort of an end point of financial distress, while the access to credit is a midpoint. There are drawbacks to any metric, and personal bankruptcy is not an exception to that. People don't access bankruptcy or file bankruptcy equally across racial, ethnic, or sociodemographic lines, and there are differences in bankruptcy practices across states. However, I am of the opinion, and I'm not an expert here, but I'm of the opinion that if we're having a big recession, we're going to see increases in bankruptcy, and that may suggest to city leaders that, hey, maybe we should raise the minimum wage or provide a whole lot of housing or some of those other ground level financial interventions. Third and finally, we're going to work with the Fed to try and just get more nuanced financial metrics, and we're going to be working with them ideally over the next year or so to create that. And so you know, you're right on it. You're right on it. We're thinking about how we can add more complex and interesting financial metrics to the dashboard, because we are going to need them in the coming years. Yeah, I would love to stay in touch with you too. Sorry, I don't mean to. Oh, I'm not the moderator. Sorry.
No, no. That actually, it looks like that was our very last question. Do you have any final comments before we wrap up today, Ben? So there is one more question here from Bettina that says, are we going to include the H1N1 flu pandemic? I don't know. My leaning towards we probably will not, because we need to concentrate our efforts on COVID, and this is something that I'm going to bring back to my team because I don't think we've thought about it yet. I guess in closing, I'll say, I'll reiterate that we want to work with folks, especially folks who are in smaller cities that may not have substantial data capacity, because the entire purpose of our program is to provide access to data where there was not access to data before. So my inbox is always open to visitors. Please email me, let us know. We'll find a way to work with you if you desire to work with us. And I very much appreciate
you all attending the webinar.
Thank you so much. And with that, we must conclude today's webinar. A special thank you to our presenters and to everyone who joined us today. Please take a moment now to complete a brief evaluation of today's program by clicking the evaluation link to the left of the screen. Your comments and suggestions are important to us as we plan future events. The survey must be completed in order to receive a certificate for this program. You can also access the survey from your ICMA dashboard by clicking on the program title once you are logged in. Thank you for your participation in today's webinar. We hope you will join us again soon. Today's program is copyright 2020 by the International City-County Management Association with all rights reserved. This concludes today's program. Thanks for joining. You may now disconnect.